Hey OncoPT, and welcome to another episode of the OncoPT podcast. Now, in this episode, we are going over some of the basics that you need to understand about prostate cancer. Despite prostate cancer being super common when we look at diagnoses as a whole, we actually really don't talk about prostate cancer that much on the OncoPT podcast. Well, we're about to change that, okay? Because we need to be prepared for when ultimately one of these patients comes into your clinic or when you roll up into their hospital room at some point, right? It's very, very common, and we're going to go over again some of the basics of what do you need to understand, but ultimately, what can you expect to see the next time that you have a person with prostate cancer on your schedule? So first and foremost, as I mentioned, prostate cancer is actually quite common. It makes up almost 15% of all cancer diagnoses in the United States, which makes it technically the most common cancer diagnosis among men. Now, big star, big asterisk here. This is technically after cancer of the skin, okay? We know skin cancer, very common. However, the reason that it's not really included in these typical stats that we talk about is because it is so common and so easily treated. They almost sometimes don't consider it quote, real cancer, which again, we know cancer is cancer. Okay, so that's why we're not really considering skin cancer in the lineup of all this. Prostate cancer, for our intents and purposes, most common cancer diagnosis among American men. Now, what this actually looks like in translation is that almost 1 in 8 men will be diagnosed with prostate cancer at some point in their lifetime here in the US. So this is huge, right? This is comparable to breast cancer in our women patients, right? So this is a very, very common occurrence. You probably have already seen some patients with this. And if you haven't already, buckle up because they're probably coming, right? Now, prostate cancer contributes to about 6% of all cancer deaths within the United States. This roughly translates to almost 35,000 deaths by cancer each year, which is the second most common behind lung cancer. So again, here's good old lung cancer, and by that I mean bad old lung cancer. Coming up, still the most deadly, but prostate cancer ranks just behind it in the grand scheme of things, which indicates to us this is still a really big problem, right? We know general survival rate for prostate cancer is about 97%, which is really, really good, but that also means that we've still got a significant chunk of the patient population who you may be seeing who has more advanced, more progressed prostate cancer, and that is something to be aware of. With that said, most men with prostate cancer are not going to die because of the prostate cancer. In general, when we compare it to some of the other cancer types within OncoPT, right, we know that prostate cancer isn't always the super fast growing, super aggressive type. In many cases, it's actually quite slow growing and may even be quite asymptomatic for most of our patients, which is why this contributes to most patients do not die because of the prostate cancer. Instead, they will die with the prostate cancer. When we zoom in on prostate cancer as a diagnosis, as a disease by itself, we see that most prostate cancers are adenocarcinomas, which means that those prostate cancers are going to develop from the gland cells within the prostate. Now, there are other rare types of prostate cancers, but I'm not even going to talk about them because the overwhelming majority, significantly, are due to these adenocarcinomas. Now, some common risk factors associated with prostate cancer, first and foremost, include having a prostate. Again, I feel like that goes without saying, but we see this. The number one risk factor of prostate cancer is having a prostate. Now, of course, there's some other really important ones that we need to talk about, which includes older patients are more likely to develop prostate cancer. We also know that certain patients, including those who are African American or Caribbean of African ancestry, are at an increased risk of developing prostate cancer. We also see that prostate cancer is tremendously more common, maybe not tremendously, but more common in patients who live in North America, who live in Northwest Europe, who live in Australia and even the Caribbean islands. Now, as a not epidemiologist, I have some thoughts on maybe like why this is, but we're not going to get into that in today's episode, okay? So just be aware, this is kind of what we're working with. And if you're like me, you're very much in North America. So my patient population is right there in all of this. We also see that a patient who has a family history of prostate cancer definitely has an increased risk of being diagnosed with prostate cancer at some point in their life. But we also see that there's certain genetic mutations and familial histories, familial patterns that can contribute to an increased risk of developing prostate cancer. So for example, BRCA1 and BRCA2 gene mutations, very, very common, very, very important when it comes to talking about prostate cancer and increased risk. We also see that patients who have Lynch syndrome are at an increased risk of developing prostate cancer, among other cancers, during their lifetime. Now, none of these, of course, guarantee that a person is going to develop prostate cancer. These are just some of those commonalities that we do see within this patient population. Now, when a person is suspected of having prostate cancer, it's usually because they've undergone some kind of screening test that has led us to that conclusion. So most commonly, I think a lot of people have heard of the prostate-specific antigen blood test. So PSA is what that will commonly be abbreviated out within the chart if you're chart reviewing for a patient. So patients will have an elevated PSA level, and that will usually trigger some kind of, hey, we need to look into this a little more. But it may also be that a patient underwent a digital rectal exam, and that cued that provider in to say, you know what, something doesn't seem right here. In many cases, patients may, of course, present with some signs and symptoms when it comes to especially more advanced prostate cancer, when that prostate is quite enlarged. Maybe it's impacting other structures. So sometimes you'll hear about that, but a lot of times this is kind of picked up because of one of those two screening tests, like I said, the PSA or even the digital rectal exam. Once prostate cancer is suspected, they will then usually undergo some kind of repeat PSA testing to see, like, are those levels actually elevated? Are they elevated over a period of time? And or potentially biopsies to confirm that, yes, this is indeed prostate cancer. Now, what's since been diagnosed? The prostate cancer, so once they've biopsied it, they've gotten a look to see what the heck is going on here, that prostate cancer will be assigned a Gleason score. And I'm not going to lie, y'all, this was something I did not understand for a really long time. So basically what you need to take away from this, prostate cancer kind of has, I won't say its own staging system, but it has a little special extra, okay? So what we see with prostate cancer is that the Gleason system, which is used to grade prostate cancers, which is, again, how differentiated those cancer cells are compared to normal prostate cells, they're going to be assigned a score. Now, there is certain criteria. You and I, as the OncoPT, are not involved in the actual assigning of the grade. I just want you to appreciate what we're working with here. So basically, it comes down to there's a two-part number system to the Gleason scale. So commonly I see like 3 plus 4 or 4 plus 3 Gleason scale. And so what you should take away from that is the higher the score, the higher that Gleason rating for that person's cancer is, the more poorly differentiated those prostate cancer cells are. And as we know, the more differentiated the cells are, generally the more aggressive, the more problematic that this cancer could likely be for that person, which is why we want to establish what the heck is that Gleason score. Now, once a person's been diagnosed, once they receive that staging and grading, now it's time to move forward with treatment. And for some patients, they may not actually start treatment, which seems a little counterintuitive when it comes to our big world of OncoPT. But the reason for this is that some prostate cancers are very slow growing and probably will not progress until like years have passed. Like it's slow enough growing that any treatment, any medical treatment that person could undergo may be even more detrimental to function and quality of life than that cancer would be. So unlike what we see with a lot of other cancer diagnoses, some patients with prostate cancer may actually undergo this active surveillance or even observation approach to treatment. So again, this is reserved for patients who have less aggressive, slow-growing, early-stage prostate cancer who aren't having any other potentially signs or symptoms, right? Who aren't having any problems associated with this cancer diagnosis. This very special subgroup, these are very low-risk patients. And they may stay in this stage for a long period of time, maybe even living out the rest of their life with a prostate cancer, not necessarily undergoing treatment. So remember what I talked about previously, which is sometimes patients will die with prostate cancer rather than from the prostate cancer. This is a big part of what we're talking about here, which is the very slow growing, very not aggressive, active surveillance or observation patients. Now, for patients who have a little greater risk, maybe slightly more aggressive, more progressed prostate cancer, they may choose to pursue radiation therapy. And this could include proton beam radiation therapy, maybe even external beam radiation therapy, but potentially also brachytherapy. And for most of my patients I think I've encountered so far, I think more of my patients have opted for the brachytherapy option. That could just be a local thing for me. I'm not saying that's what the case is in your area, but I think that's what the majority of my patients so far have undergone if they have gone through radiation for their prostate cancer. Typically with the brachytherapy, it's usually going to be that seed or pellet implantation approach. So we've got our prostate, and then they will insert little radioactive quote beads inside or very, very near to the prostate to deliver that low-level continuous radiation therapy to the tissues. Now, for some patients who maybe need next steps in treatment, right? Their cancer is a little more progressed, it's a little more aggressive. They may choose to undergo a prostatectomy in lieu of or in addition to radiation therapy, right? So radiation therapy or prostatectomy could be a first step for some patients. It could be it's not an either or, it's a both. And in those cases, available options for patients who choose to undergo a prostatectomy could be a laparoscopic procedure, right? Maybe that's a laparoscopic prostatectomy. Maybe it's a radical prostatectomy where they truly are removing all of that prostate instead of just part of it. And some patients may also undergo transurethral resections of the prostate. So if you are looking in a chart and you ever come across TURP, T-U-R-P, that's what this is referring to here. So just keep this in mind. Now, I will let you know, I am working on getting a prostate cancer expert on the podcast to discuss these options further. So I'm not going to go into too much depth there. Stay tuned, because I know when I do get this guest and our interview recorded, y'all are going to love it. So like I said, Put a bookmark in it, put a pin in this. We're going to come back to it here shortly on the OncoPT podcast. Now, hormone suppression therapy is another common modality for patients who have hormone-sensitive prostate cancer. So if you think to our patients who have breast cancer, they will commonly test for estrogen receptor status, progesterone receptor status, and then also for HER2, right? They also are going to do something similar for our patients who have prostate cancer to determine is hormone treatment going to be effective or beneficial when it comes to the particular, this person's particular cancer diagnosis. So some of these hormone agents that they may undergo could be LHRH agonists, LHRH antagonists, and even anti-androgens. Now, to kind of zoom out and look at some of these categories here, some common agents that we will see in the LHRH agonist category are going to be like your leuprolide, your triptorelin, your goserelin, for example. Your LHRH antagonists will be like relugolix. I'm so sorry if I'm saying that wrong. Relugolix or degarelix. And then some anti-androgens that you'll potentially see are flutamide and nalutamide. For patients who have advanced prostate cancer, they may actually choose to undergo chemotherapy. So at this point, the disease is maybe a little more, it might truly even be systemic at this point. We need to get a systemic agent on board. So keep in mind, for patients who have prostate cancer, chemotherapy is not the first line option like we tend to see with some of our other cancer diagnoses. Some common agents that we'll see when it comes to chemotherapy in prostate cancer could include docetaxel, cabazitaxel, methoxytrone, and estramustine. Now, with each of these agents, some common agents that you may see your patients with prostate cancer treated with in the chemotherapy side of things could vary. I've seen some taxane-based chemotherapies. I've even seen a couple platinum-based chemotherapies. This is very anecdotal. Okay, keep that in mind. So what I would really encourage you is if your patient is undergoing some kind of chemotherapy or has undergone chemotherapy for their prostate cancer, really dive in. Another always good resource is the 2017 article by Malter et al. Entitled A Focused Review of Safety Considerations in Cancer Rehab. They've got some great info on side effects, and I will bring it back around. We are actually going to talk about impairments and rehab implications shortly. So put a pin in that and make sure if you don't already have Malter, that article saved, do so now because it's going to be extremely helpful when working with this patient population. Now, with the ever-expanding landscape of immunotherapies and targeted therapies available to our patients, you are definitely going to see these at some point in your career used for the treatment of prostate cancer. So current treatments may include cancer vaccines. So this is not to prevent cancer. This is a vaccine that is used to treat the cancer. Okay, there is a difference there. We've got immune checkpoint inhibitors. We've got PARP inhibitors, and there's truly a list of others that even if we're not seeing them super commonly now, I do anticipate we're going to see them in the future. So keep this in mind because I do believe that immunotherapy and targeted therapies, based on trends we're seeing in other diagnosis patient populations, we're going to see the same expansion within prostate cancer treatment within the next few years. While only 8% of patients are diagnosed with metastatic prostate cancer initially, I previously saw several patients with metastatic prostate cancer in my own practice, okay? So I am speaking very anecdotally here. And what I saw a lot of were patients who had bone metastases and the very corresponding considerations that I would need to be aware of and concerned for within the scope of bone metastases in our oncology patient population. So a lot of times, in addition to the other treatments that I've already talked about in this episode, I also had many patients who were on treatment for their bone metastases. In some cases, this included the use of bisphosphonate treatment, even denosumab, but also corticosteroids. Now, I could have seen, if I'm thinking of any, they're kind of escaping my brain right now. We could also see patients undergo non-medication therapy for their metastatic bone disease, right? So maybe that's even like a surgical fixation. Maybe that's a radiation therapy to try and halt or stall that progression of disease as much as possible within the bone, right? So not just from a medical treatment side of things as far as like I take a medication, but don't forget about these other treatments that we commonly see used for patients with metastatic bone disease. And the likelihood, because I'm thinking of one particular patient who had metastatic bone disease, who was going through chemotherapy, that person had quite a few side effects that we were dealing with in this very multi-layered fashion. I know, it's kind of like the story of Cancer Rehab of OncoPT. But that was something that I really, especially as an early career clinician, really struggled to kind of put it all together with, okay, I've got my chemotherapy medication, side effects over here. Also, they did chemotherapy previously and that caused side effects. And now we've got this malignant bone disease, right? That is also contributing. And so now I've got medication that this person is taking for that. You get the picture, right? So it's really, really important. Make sure that as you're working with this patient population, you are gathering as much information as possible. And even if you don't know necessarily what to do with all of that oncology treatment history stuff, take it down, because you can always go back and look and investigate further. And that is totally appropriate. That is totally acceptable. Okay, we allow that. We encourage that here on the OncoPT. Now, for this episode, I'm going to break down some of the more common side effects that you can see in this prostate cancer patient population, okay? And what I'm doing is slightly different than how I've done this in some previous similar episodes. Is I'm breaking down those side effects by the treatment approaches. So kind of recalling or remembering that order we talked about. Don't worry, I'm going to make sure that you know exactly what that is. I'm going to break it down by potential signs and symptoms, side effects, impairments, etc. that I could see and that I have seen based on the various treatments for prostate cancer. So first up, our first line of treatment that we tend to see in the prostate cancer patient population is that active surveillance and observation. And in this scenario, I could expect to see that my patient could have some musculoskeletal impairments that are totally unrelated to their cancer diagnosis, period. Like, one that comes to mind immediately is rotator cuff dysfunction. And oh yeah, now I happen to also have prostate cancer, for example. That is a possibility. And in that case, obviously treat the musculoskeletal impairments that you find, right? Now, when we get into radiation therapy, this is where we start to see some more side effects, right? So as you know, radiation therapy is a big old burn, right? It's a big sunburn all the way through the tissue. And so because of that, as I know you already know, radiation therapy affects every tissue that it passes through. And don't forget, radiation therapy doesn't just go in, part of it is also going to go out the other side. So don't forget about this. So patients who undergo radiation therapy for their prostate cancer may experience locally pelvic floor dysfunction, right? Even with brachytherapy, we know that radiation causes collateral damage to the surrounding tissues. And while we're getting better, while we're getting more precise, we should still expect side effects from radiation therapy, period. And I'm going to go on record and say, regardless of the modality or the approach, there are always going to be side effects. I welcome the day that I'm proved wrong, but until then, that is the hypothesis that we should be operating under, especially for this patient population. So of course, we've got our pelvic floor dysfunction, bowel, bladder, and sexual dysfunction. These patients could also experience damage, trauma, injury to their lymphatic system. So maybe we've got some local lymphedema issues that we need to be concerned of and screening this patient population for. Fatigue is also perhaps one of the most notorious side effects related to radiation therapy. No joke. A couple weeks ago, I went to a dance class with one of my friends here locally, and it was one of those like lyrical jazz dances. Don't worry, I was in the back where most people couldn't see me because I'm not very good, but I went because it's exercise and it was fun, and I really enjoyed spending that time with my friend. But as we are coming out of this like recreation center where I have never been before, I'm walking out and I happen to catch a glimpse, y'all, no joke, the side profile of this person who was walking kind of in front and to the side of us. And I recognized that this person was a former patient of mine. And so I, as non-creepily as I could, called out this person's name and was like, oh my God, I don't know if you remember me, but I used to work blah, blah. And like, that's all that I say. So that way, if, like obviously I'm wrong or whatever, they don't actually, know whatever. But anyways, this ended up being my patient. And it was such a beautiful moment to be like, oh my God, how are you? Da, 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 da. And the one thing that this patient left me with was I am still having that fatigue from my radiation therapy. Like, that was the whole reason that I saw this patient initially, is that the fatigue was overwhelming to the point that this person wasn't able to do their job and couldn't focus on their very cognitively demanding job. So anyways, it's been a really interesting growing experience as a clinician over the past few years to recognize, I know on paper that radiation therapy can cause a host of side effects, and one of those includes fatigue, but the fatigue that my patients have experienced from radiation is truly debilitating, and I don't think I really put as much weight to that until working with this particular patient, and they changed my whole paradigm and perspective on radiation therapy associated cancer-related fatigue. Anyways, that was a very long and roundabout way of saying radiation fatigue is real and it lasts. So if your patient has had radiation therapy, is going through radiation therapy, we need to be screening them. We need to be talking to them about this because it could potentially affect them very, very significantly, much more than I think a lot of times we really think, right? While you tend to think of brachytherapy as having less side effects or less severe side effects compared to external beam radiation therapy, we actually find that it's kind of the presence of radiation therapy that contributes most to sexual dysfunction rather than the type of radiation therapy, which is really interesting and kind of goes against what my initial thought would be with this patient population. So specifically what we see is that there seems to be more of a tie between sexual dysfunction after radiation therapy for prostate cancer to age and presence of sexual dysfunction, sexual function before treatment. So that is something, again, don't assume just because your patient had brachytherapy that they're not having pelvic floor issues or that they're having less severe pelvic floor issues, because that may actually be false altogether. And I think in the coming years, we're going to pull more as far as what is that correlation between radiation therapy, age, sexual function prior to treatment, and how it all works together. So again, stay tuned on that. Now, hormone therapy, like I said, can be common depending on your patient's prostate cancer characteristics as well as their stage, grade, etc. So patients undergoing treatment with LHRH agonists, that would be your leuprolide, your goserelin, your triptorelin, as well as the LHRH antagonists. So the LHRH agonists and the LHRH antagonists, those kind of go together here. These both will cause bone pain as well as bone thinning. So this is where those bone density issues come in. Sexual dysfunction, anemia, cognitive dysfunction, hot flashes, gynecomastia, loss of muscle mass, weight gain, fatigue, and depression in patients. Will they contribute to all of those side effects in all patients? No, but there's a good chunk that they could definitely experience a few on that list. On the flip side of this, for patients who undergo treatment with our anti-androgens, so your nalutamide, nalutamide, and then flutamide, these patients can experience muscle wasting, osteoporosis, and erectile dysfunction, but this erectile dysfunction specifically may be less severe compared to when the patient is on some kind of LHRH agonist or antagonist. Now, that's not to say that the muscle wasting and the osteoporosis side of things isn't quite problematic for these patients. And what I really want you to take away from this is that no matter the agent it seems that patients will undergo, what type of hormonal therapy that patient is undergoing for their prostate cancer, bone density issues are absolutely a commonality among all of those. Muscle changes are a commonality among all of those. Pelvic floor dysfunction is a commonality among all of those. Now, how that manifests in your patient could be very different from, one patient to the next, right? We expect this. We know that every patient is different. But I would really, really encourage you, these are some 3 key areas to pay attention to with your prostate cancer patient population and some of what they may be experiencing, and perhaps most important, how you can best intervene to address some of those impairments your patients are experiencing or could come to experience as treatment goes on. Now, I do want to close here with chemotherapy. As I mentioned previously, chemotherapy is not first-line therapy for your patients with prostate cancer. However, for the patients that I have seen with metastatic prostate cancer, they are, or at least have been, the ones I've seen, have undergone chemotherapy. So again, commonly I've seen taxane-based chemotherapies. I've also seen some platinum-based chemotherapies used. I know there's others, but I'm just letting you know that's been my experience so far. That was also a few years ago. Like, it could have changed in the past couple years, and I just don't see a lot of that patient population right now. However, I do anticipate that is going to change very, very quickly. So looking at those, specifically those taxane agents, because I know that those are more commonly used in the metastatic prostate population. Taxane-based chemotherapies can cause peripheral neuropathy, hello CIPN, as well as cytopenia, and in some severe cases, even acute myocardial infarction. Now, I have not yet, because I've only been practicing 5 years, I have not yet encountered that acute myocardial infarction, and I pray that I never do. But I will let you know, I have definitely encountered the peripheral neuropathy and the cytopenia when it comes to my patients. There was one patient in particular I remember who, he was just always, oh gosh, bless his heart, he was just always kind of sickly. And I think it had a lot to do with he was undergoing, of course, chemotherapy, and his counts were so low. Like, he always just seemed to have kind of like a little cold brewing or present at all times. One of the things this patient also was very, very frustrated with is he was previously very, very active. He actually refereed basketball games in the community, and that was one of his favorite things, is he loved to run up and down the court and keep up with the players as, of course, they were playing along the court. Also, that's like part of the refereeing position, as far as I've been told, as someone who has never played basketball. And for him, the treatment that he was undergoing really contributed to, of course, a lot of fatigue, like we talked about. But for him, the muscle wasting and the weakness that he developed as a result of this was very, very prominent. And for him, he very much presented with this kind of, quote, menopause experience. So he had weight gain in addition to the muscle wasting, right? That muscle weakness that came as a result of that. So that was a big issue for him. He was also very, very prone to mood changes. Particularly, depression was big for this patient. And so one of the things that we really worked on, actually, like over a very significant extended period of time when I was working with this patient, is his depression would very much come in waves. And so getting psychological support on board to not only, of course, help with the depression side of things, but also the coping and the mental aspect of balancing all of these very, very significant side effects that he was experiencing as a result of his prostate cancer. And that's one of the things, again, I saw a really, really great post the other day on LinkedIn. I think it was from Matthew Johnston, who, if you haven't followed him already, definitely follow him on LinkedIn, because he posts a lot of really good information when it comes to especially like male pelvic health. He talked about how common it is for male patients to not discuss their pelvic floor dysfunction, their pelvic floor issues with their families even, but also like friends and healthcare providers, right? This is not something that's talked about. And while I'm not equating them, I do believe that the mental health, depression side of things is also a big reporting barrier for patients. And I would really, really challenge you, dig into that with your patients. You may be surprised how many patients are experiencing those mood changes, that psychological distress, that depression that can sometimes accompany these different treatments for prostate cancer, as well as, of course, the prostate cancer in general. So really, I'm challenging you for the end of this episode, right? Your homework is, I really want you to lean into screening your patients for this, to asking those questions and not just making it a one-off thing, but asking the question throughout your episode of care, because that may change and you will need to change your response to those circumstances, whatever that is for you, whatever is best needed for your patient at that time. So without further ado, I so appreciate you tuning into this episode of the OncoPT podcast. What I would love for you to do, I don't usually ask this, but I really would like for you to do this today. Please go within your podcast player, and I would really love it if you would leave a 5-star review for the OncoPT podcast. It helps other physios, physical therapists, but also students and other people who are interested in this amazing world of cancer rehab to find the podcast and ultimately better help their patients because of the information that they are learning through that experience. So again, I would really appreciate that. Again, it's quite easy. It's quite fast. Go into your podcast player, leave the OncoPT podcast a 5-star review, and I cannot wait to see you in next week's episode. Until then, this is Elise with the OncoPT podcast. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.